in today's morning rounds, we talked about the facet joint. I was just thinking about it, like lots of patients come into clinic and they say, I've got a bulging disc and I've got degenerated discs. But I have yet to hear a patient come into clinic that says, I have an arthritic facet joint. Have you ever heard that before?
No.
Primarily, I feel like patients come in, like you said, knowing the disc problem. I don't know why that's the common nomenclature and the common problem that the community knows about and that everybody hyper-focuses on. But yeah, I like the discussion today helped us get away from that and see what probably is the more common complaint in medicine, which is the mechanical back pain.
Yeah. So let's talk about the motion segment of the spine briefly. So there's 3 structures involved, right? There's the 2 vertebral bodies, the disc, and 2 facet joints at every segment. So there's twice as many facet joints as discs. How would you explain to a patient what a facet joint is?
So one thing that came up today in rounds that I found pretty interesting was when someone comes in and they've sprained their ankle, they can identify that pain. They're like, oh, I twisted my ankle and I've sprained it here. And so kind of explaining to a patient, it's a similar mechanic where you've got this kind of joint that you can injure or it can cause pain. I thought that was very helpful.
Yeah, like the discs we know is like a cushion, right? They're a shock absorber and they provide some stability. The facet joints are a little bit like other joints in the body. They have a capsule. They're subject to being sprained, like an ankle. And I thought that was a good example. You can sprain your back just as much as you can sprain your ankle and vice versa.
One thing that I've tried to do a good job of is educating the patient on the understanding of the biomechanics of the spine. So when you break down an x-ray to them and you explain to them, here's your vertebral body, but there's a joint on the backside, and your spine is composed of many joints, and they all work synergistically together or in opposition, depending on the underlying spinal biomechanics. And I think it's been a great thing to be able to share that information with patients so they understand. And when they see their facet joint and they see that it's arthritic and they see that it's causing stenosis or some other malalignment issue, then you can start to help them realize what's actually going on. And then when you explain the treatment modalities that can be offered to them, I think they're much more willing to listen and take that advice, whether it's seeing a chiropractor for a spinal biomechanics assessment, working with physical therapy to strengthen their muscles to help encourage that foundational strengthening support for their spine. So I just think, and then obviously the last thing would be surgery if it's necessary.
So understanding the anatomy and the associated problems that occur can help patients understand why we're recommending certain things, why they may consider certain things. You mentioned that the facet joints are in the back part of the spine, and just in a simple way of thinking about it, which is actually how I think about it, is you have your discs and your vertebral bodies in the front stacked up on top of each other, the spinal cord and the nerves in the middle, and then the facet joints and the back part of the spine in the back. And they are all working together at each segment, but are subject to different problems along the way. There's a lot of ligaments involved in every joint of the body. A ligament supports a joint, right? Tendons attach a muscle to a bone. Ligaments really support a joint. And how is ligament problems relevant to facet joint issues?
The ligaments are what compromise the stability of the segment. And just like any other joint, if it's loose or if they're injured tissue or diseased tissue, I really like a few weeks ago when Dr. Gary Edwards discussed diseased tissue when he's talking about tendons through the shoulder joint. And it's a very similar process. If it's just not functioning well, then the whole segment becomes loose and a little bit floppy, and that kind of motion is not appropriate and it causes pain.
And one thing to that end, it is difficult to isolate a ligamentous injury in the spine. I think you have to look at it pretty deeply. And I think you brought up the point today about the facet joints, and when you see their gapping on the MRI and you're seeing facet joint effusion, it is very helpful to get dynamic weight-bearing x-rays because you might actually pick up on something early on where there's segmental instability, or if it's a multi-level problem.
Yeah, one of the themes is we sort of forget about the facet joint. And one of the reasons for that is the ligament pathology involved is hard to see on an MRI. It's not that easy to understand. We do have X-ray, dynamic X-ray as a surrogate for ligament laxity, but that's always been a really difficult thing in spine to pinpoint. Like your ligaments are injured and that's why you're hurting, because you can't see it very well on imaging. Let's talk a little bit about the innervation to the facet joint. How do we know if a facet joint is painful? Like how does a patient feel that? What nerve goes to the facet joint?
So in your facet joint, you have your medial branch nerve that goes through there, and it innervates that area where I think patients don't really recognize that this is something that is innervated as by a nerve and can cause pain. And so maybe educating them to that and knowing that we can go in and actually address this nerve or do a diagnostic injection or something to see, is this where the pain is coming from, can be very helpful.
So when they say medial branch, it's a little branch off of the nerve coming out of the spine, and it goes to the facet joint. And some patients will have what's called a medial branch block, which is a diagnostic test to target that nerve and see if it alleviates the pain. So that's done pretty frequently, and I think patients are like, medial branch block doesn't mean a lot to them, so hopefully that makes sense to them. It's not targeting pain from a disc, it's targeting pain potentially from that joint and its surrounding ligaments.
And when I'm working up patients in clinic, one of the things that we try to isolate is the type of pain that they're actually having. So there's anterior column pain and posterior column pain. And I try to help the patients understand what the difference would be. So subjectively, they might say that back extension, things where they're loading their facet joints, actually causes more pain, versus bending over. The act of actually bending over is what elicits pain. And through that, you can start to isolate maybe what type of pain they're having. And then you look at the MRI and the X-rays and you isolate if there's a facet problem. Then you would want to do some diagnostic testing to see if that is in fact the case. But I think it's important for the patient to understand the different types of axial pain one could have. So,
yeah, we didn't get into the discussion on this, which is why, and I meant to, there's only 30 minutes, right? So we're going to do a round 2. And I think one of the questions I'm going to start with is, how do you identify facet-mediated pain on history? And there may be when I bend back, I hurt more. That could be loading the facets more. We have a medial branch block as a diagnostic test. We can look at imaging, both dynamic X-ray, MRI, to get some idea. And I think that can help guide decision-making as to how we should treat it. I was hopeful in this morning's discussion just to highlight that the facet joint is a really important part of underlying spinal issues, degenerative cascade of events. It can be an important source of pain and disability, but we just don't think about it. And so hopefully patients and clinicians can be recognizing where facet joint issues are occurring and prevent further degeneration and get the appropriate treatment lined up. And again, I think we're going to revisit this because I sat down to do the talk and I was looking at my messages from the weekend, and I had about 15 messages. And in about 15 messages, I had my talk because 10 of the 15 patients were relevant to this discussion. It's so common. And so next time we meet, we'll talk through some additional cases relative to the facet joint. So, all right.
Perfect.
Thanks.